Good evening, everyone. In our third season of the AOCN Web Academy, we are very honored here to have Dr. Bejoy Thomas again. He is a very popular choice as a speaker, and we've been waiting for the session for a very long time now. Dr. Bejoy Thomas is professor of neuroradiology at the Department of Imaging Sciences and Intervention Radiology at Sri Chitra Institute of Technology and Medical Sciences, Trivandrum. And he's an excellent speaker and he's an expert. He's had special training in pediatric neuroradiology from sick kids. And he'll be talking about basics of proton MR spectroscopy for pediatric neurologists. Over to you, sir.
Thank you very much, Dr. Suvasini. Good evening, all of you. And thank you once again for inviting me to AOCN for this lecture on basics of H1MR spectroscopy, basically designed for pediatric neurologists. So we know that spectroscopy is a very difficult topic in order to master, not only because of the complexity or the physics of this, and also because of the technical challenges we face when we are actually doing spectroscopy. When we really want to get a good spectrum, we will not get a good spectrum, and most of the time, most people think that it is giving only a redundant information. But it is not true. If you actually use it in the correct method and the correct use, spectroscopy is a very useful technique, and MRS is a non-invasive method providing metabolic information of the tissue, which is not available with MR, or even when MR abnormality comes, even before that, you can actually see the metabolic abnormality in spectroscopy. Having said that, it has got a significant limitations, especially when you're actually not giving enough attention to techniques and how optimally spectroscopic imaging has to be done. It is always used in adjunct to MR imaging. So what are the basic principle? We use the proton is the largest number of the molecules available in your body, and we usually use an H1 proton spectroscopy, although we can do phosphorus and other spectroscopy. But the most commonly used is the proton spectroscopy. We'll talk only about proton spectroscopy in this talk. So we know that the nucleus is actually surrounded by electrons, and this electron cloud around any nucleus is producing some amount of a reduction in the magnetic field, which is observed by this the main nucleus when it is actually placed inside a large magnetic field or a strong magnetic field. So this is the modified Lamer equation, where you can see omega I is proportional to gamma B0 1 minus sigma. The 1 minus sigma is contributed by the electron cloud. Because that the Lamer frequency is slightly different in tissues, because of this electron cloud is different between molecules, so you see a difference in Lamer frequency, which is actually basically the basis of the physics basis of chemical shift imaging or MR spectroscopy imaging. So we don't have to know a lot about this, but what we basically understand is that we are looking at spectrum basically as a result of a free induction decay, and we are looking at the chemical environment which is actually designed by the electron cloud around this nucleus, and all the interaction of these electron cloud to the adjacent molecules, which is the base of J coupling and all. We will not go into the details. I will not actually bother you with much physics. This is the last physics slide I'm going to show you. So basically we are actually getting these time domain signal is actually converted into frequency. And in H1 MR spectroscopy, if you see that why we can see that the ppm scale is from the right to the left, because the lowest frequency is depicted on the right as 1, and then towards right as higher ppm scales. So this is because even before MRI or MR spectroscopy, there was NMR and NMR spectroscopy. They were using a technique called field sweep. We know that our MR magnet, the main magnet, the field strength is pretty constant. Once you buy a machine, is 1.5 or 3 Tesla. But when they were using NMR spectroscopy, which is developed in 1940s by Blow, Purcell, Harvard, and Stanford scientists, they were using a technique called field sweep, and they were keeping the RF frequency constant, and they were changing the magnetic field. So they had this convention, and even though the present day computers can um, actually scale it from the right left or the left right, but we are actually using it. And why we are using a ppm scale? Because if you look at 1 Tesla and 1.5 Tesla, the fat and water are actually separated by 150 hertz and 225 hertz between 1 to 1.5 Tesla. But if you keep changing it, if you measure everything in hertz, for every change in magnetic field or a field strength, you have to by heart what all these peaks are actually depicted in. But fat and water are separated both in 1.5 Tesla and 1 Tesla by 3.5 parts per million. So in order to have a constant depiction of these metabolites and the chemical shift frequencies of these metabolites, we are using a ppm scale. And what is in that is in the x-axis. What is in the y-axis? Y-axis is actually giving a peak, and the area under the peak or the height of the peak. Then basically the area under the peak is the integral, and which gives an idea about the concentration of that metabolite. And we need to have a certain amount of minimum amount of concentration in order to detect these metabolites in spectroscopy. What are the largest metabolites detected in spectroscopy is basically fat and water, and we don't want to see them. So what we do is suppress the fat and water so that we can actually see the micro metabolites or small metabolites, and which we are interested in, the Na, creatine, and choline, and all, which I'll talk to a certain detail in the next few slides. So what we have learned till now, we have different metabolites actually demonstrated in the the x-axis, and the height or the integral of this peak in the y-axis is giving a relative idea about the concentration of these metabolites inside the brain. So is that clear? So now how this ppm scale is developed, because in 1.5 Tesla, reference substance called tetramethylsilane is used, and that is considered to be ppm 0, and water is at 4.7 ppm. And nowadays we use the water reference because water is the easiest to be detected in spectroscopy, and which is suppressed by chemical shift, chemical chest suppression methods. And so that's why we are not seeing normally water signal in your spectroscopy. So spectroscopy, like I've told, if you are actually leaving everything to the technologists, or it is not going to work. One radiologist has to actually monitor when the spectroscopy is being done. The Voxel placement is very, very critical. The outer volume suppression bands, which is actually the shimming of the coil, the shimming of the system is very important. And the outer volume suppression bands, how we keep these bands, are very important. And we have to avoid the blood and adjacent bone from these voxels. And also the good shimming is very important. That is depicted by the maximum level, full width, half maximums. These are all technical things which I'll go not into the details because of not industry you. But you should always actually insist that radiologists will be monitoring. We should be monitoring this when the spectroscopy is being done. And the post-processing techniques and the ratios are also, and basically we will talk about pitfalls of spectroscopy in this talk. This is how you do a spectroscopy. You do an outer volume suppression in order to get a good signals from the voxel of interest. These are very large voxels of the order of several centimeter cube, not like your MR voxel. So it is at least 1 by 1 by 1 centimeter cube or a 2 by 2. And if you're using a single voxel spectroscopy, you usually use a 2 centimeter cube voxel, because in order to get a good signal from these voxels. And it is actually possible with some partial volume averaging, and we'll talk about that. And the strongest of the outer volume suppression is the first band, and which has to be kept accordingly. I'm not going into the details. Now the question is 3 Tesla or 1.5 Tesla. More important is actually the clinical spectroscopy is not the magnet strength, but the shim of the system. So unless your MR machine has got a third or higher order shim, or how homogeneous the magnet can be made, you are not going to get a good spectrum. This is a 1.5 Tesla spectrum, and this is a 3 Tesla spectrum. So these are very important. The higher the magnetic field, spectral separation is better. but it's mostly important for research purposes. In the clinical spectrum, you can get very good clinical spectroscopy even on a 1.5 Tesla scanner. More importantly, to get a good spectrum, and if you're actually getting, this is a spectrum which we tried from a supposed to be meningium of the intracornal locations, the optic nerve sheath meningium. If you put a voxel there, you are not going to get good spectrum. So it is not possible to report on these things. So this is where you should understand that when you don't get a good spectrum, it is better not to report on that spectrum rather than making a mistake. The question is that what technique we use is a single voxel spectroscopy or a multivoxel spectroscopy, as it was called, a chemical shift imaging. I'm sure that you have actually seen single voxel spectroscopy and multivoxel spectroscopy in many of your referred cases. And usually we use a single voxel spectroscopy when you don't have much time, and because you can get and it's a generalized disease, for example, metabolic disorder, where wherever you put the voxel, you get, and you basically select your voxels based on your basal ganglion, the peritrigonal, and the centrum seminal white matter, where you're actually interested in. But the problem with the single voxel spectroscopy is that you cannot actually compare with the adjacent voxels. You get only spectrum from that voxel. I've told that spectroscopy works on the principle of a chemical shift imaging. Even if you put a voxel here, you're actually getting a spectrum which is from the adjacent voxel. So you'll not be able to extract from this coming, though there are actual localization techniques are there, but it is not like an MR localization. There can be some chemical shift and chemical shift based the phase shift as well. More importantly is that to get a good spectrum. For example, this is a single voxel spectrum which is from this pontine area, which is very close to the Petrus bone. You can see a lot of spectral details. These are actually not these multiple micrometabolites are actually a baseline corruption. These are actually artifacts. So this is very, very important to understand, and actually before going into interpreting them. And the multivoxel spectroscopy, you can get a 2D or a 3D multivoxel spectroscopy. You get multiple voxels. The advantage is that you can make these beautiful color maps, which will be very interesting for the neurosurgeons, especially when they are actually taking a brain biopsy. You can get a multiple voxels, adjacent voxels, even though the spatial localization here also is a problem. And this is more clinically useful, but it takes more time to get it done. So the third question is that where to put the voxel of interest. I've told that when you're actually keeping it very close to the bone, or when there is blood or a susceptibility areas, you are not going to get a good spectrum. So you have to get the area of interest should be in the center part of the spectral voxel, so that you get a very good idea, very good spectrum, and the outer shimming is actually not covered in this voxel of interest. So you would have already heard that use low T, intermediate T, and high T, or a T is time to echo, which is used in spectroscopic methods, and why we need to do that, and which T is important. So there are different people actually prefer, if you are doing only one spectroscopy image, different people use, depending on your clinical case, this may vary. For example, in a metabolic disorder where you are actually looking at minor metabolites, you will be interested in doing a T30 or a low T or T35 millisecond spectroscopy. Usually now we can do with point result spectroscopy, both low T as well as intermediate and high T. Previously used to do steam sequence. I will not go into the details of these sequences, but press sequence is a point result spectroscopy, but that is not really important. More important is that the T values which you are using, depending on the T values, you can have the spectrum can change. If, for example, this is the spectrum which is T30, and this is the intermediate T, which is 135 milliseconds or 144 milliseconds, depending on the machine you have. Basically, they give the similar this thing, 144. Basically, if you want to quantitate lactate, you need a 144 millisecond spectrum. Basically, the difference is only in research purposes between 135 and 144. So whatever your machine is optimized for that intermediate T, it has to be used. Just because it is published literature says it's 144, should not change that. Need not change that in your scanners. So this is a long T. It is a 270 millisecond now 1.5 Tesla machine, which is very rarely used. I'll tell that why it is, because usually the spectroscopy take around 3 to 4 minutes to do get a single voxel, and the multivoxel may take even more time. So we have very limited time. Spectroscopy is added or decided added at the end of the already long sequence. So you have to clinically actually validate the use of a spectroscopic sequence. You cannot actually run a spectroscopy for each and every case, and I will tell why. Because it takes time, and if you don't get a good spectrum, you may have to repeat it. So only when it is really useful, that's why I will show a series where it is really useful and where it may not be really useful. So this is a 30 millisecond spectrum, and this is 135. This is intermediate T, and this is the long T. So the question is, which are the common peaks? So we will talk about the common peaks. Uh, so uh, so we can see in the T30, you use. I think I'll answer the questions at the end, because it will take away the flow from me. So if that is okay. So this is a T30, which is a low T spectrum. We can see multiple peaks. One is at the 0.9 ppm, and the other is 1.3 ppm. So these could be a lipid lactate and a complex, or a macromolecular complex from zero point 0.1 to 1.3 ppm. Then you get a 2 ppm, you get the NAA, N-acetyl aspartate, which is a neuronal marker. On the left side to 2.4, you get the GLX peaks, which is the glutamate and glutamine peaks. So glutamate and the GABA are one of the few neurometabolites you can actually, see neurotransmitters, not the metabolites, neurotransmitters, which you can actually study with H1 spectroscopy, because it is, I hope I'm audible. Dr. Subhasini, am I audible?
Yes, sir. Yes, you're audible.
Okay. So this is really important to know this, because to study the neurotransmitter when they are in the normal concentration, usually GABA and GLX, the glutamate, which you can actually study, because you need at least 0.5 micrograms per micromoles per gram of tissue of these substances to accumulate in order to have a critical concentration in order to get detected by spectroscopy. You know that you have to suppress water and fat, and then only you are getting this. And basically we are using only water suppression, and you are still seeing the fat there. And this is really important for our diagnosis. Then you see at 3 ppm or 3.02 ppm, you see the creatine, the first creatine peak, and which is actually a combination of a creatine and phosphocreatine and some other parts. And you can see another peak, which is the second creatine peak, which is at 3.9 ppm. So then you see the choline. So all these larger metabolites are actually not well seen and not very quantifiable, but you see the minor metabolites like which has got a low T2 value, which are actually seen in a T30. We're coming to T135, which is actually a mainstay of health if you're actually looking at, for example, bone tumors, or the brain tumors, or other conditions. And most of the time we end up doing both the low as well as intermediate T spectroscopy. So this is the intermediate T spectroscopy we like a lot, because because it gives very clean spectrum, and you can see an A peak at 2 ppm, and this particular condition, which probably in this particular case you can see at 1.3 an inverted peak, which is lactate. So what is in the upward peak in the lactate or a lipid complex, where in the 135, because of the J coupling, it is actually going, and this doublet is also because it's a doublet because of the J coupling, and I will not go into the physics of it, and it is actually again depending on the electron cloud and interactions. And because this doublet is giving us that, because it is getting inverted in T135, we are sure that this is not lipid, this is lactate. And a small amount of lipid is, the lactate is normal in the preterm babies, but not in the normal adult brain or a normal term child. So any amount of lactate is abnormal, but you have to be very careful that your baseline undulations can actually give a false impression of the lactate being there. and this is at 1.3 ppm. So we have seen that all the lactate, which is this is not exactly the same case. That's why you're not seeing the same thing. So we see that at 2 ppm or 2.02 ppm, the largest peak now you see is in an adult brain or a child who is more than 2.5 years is NAA or N-acetyl aspartate peak. Actually, you are looking at the methyl group of N-acetyl group of this particular compound. We have seen that the GLX, which is called the glutamine and glutamate, which is from 2 to 2.4, and which is getting suppressed, which is seeing as a very small peak here, and which is normally sometimes most of the time seen, but most of it is actually suppressed because it has got a low T2 value, and which is getting suppressed in a longer T spectroscopy or the intermediate T spectroscopy. At 3 ppm, you have seen again you can see the creatine peak. Here you see the second creatine peak is actually becomes lower in height or integral. And at 3.2 ppm, you have the choline peak, which is actually a membrane marker. And most of the time we are looking at choline, creatine, and N-acetyl aspartate. So choline is actually a cell membrane turnover marker, and also if I go back, you see at 3.5 ppm at the low T, 3.56 ppm or 3.59 ppm, whatever, between 3.5 and 3.6. So you can see a -etol peak also, which I will talk in the subsequent areas. So basically, we are looking at 3 or 4 peaks, and I will talk about more peaks as and when it comes. But basically, we should know 3 peaks, which is N-acetyl aspartate, which is actually at 2 ppm or 2.02 ppm, which is at 2 ppm for all practical purposes, which is actually a neuronal marker. And then the creatine, which is at 3 ppm, which is the energy marker. Metabolism, whenever there is actually infarct, a tumor, the creatine can come down. But it is previously thought to be a relatively stable metabolite. That's why people developed a choline creatine ratio and all, which I will talk about that later, which I don't believe in them. And 3.2 ppm, you have the choline peak, which is actually a cell membrane marker or a membrane turnover marker, which is actually increasing in malignant conditions where there is a proliferation is there, and also sometimes in demyelinating conditions. So if you look at the literature, it's actually flooded with a lot of metabolites, and it is everything is really useful. And if you are doing, if you are a pediatric neurologist, and I think you should be encountering them once in a while, and we will not go into the details of each of them. And this is what a normal spectrum looks like. We talk about choline, creatine, and Na. In a supratentorial brain, the choline, creatine, and Na are actually in the integral is actually in the order, the ascending order like this. So in a tumor, when there is a tumor, for example, it's a low-grade frontal glioma, you can see the choline is increased, Na reduced, and the creatine is also slightly reduced or relatively stable. So the angle, which is subtended by connecting the uppermost the peaks of the choline, creatine, and Na is actually looking upwards. It's a 45-degree angle, whereas in a tumor, an abnormal tissue, it's the angle is reversed. This angle is called the Hundus Angle. If you believe in these measurements, we can look at that. But it's basically the choline increase and Na reduces in a pathology. That's why the non-specificity, basically the balance of life tips if these metabolites changes. But there are caveats, and the caveat is that in a very young child, especially in the neonate, and the children up to the age of 2.5 years, the choline can be a higher peak because their Na neuronal development is not complete, myelination is not complete. So the high choline and a lower Na is a normal finding in a normal infant and a young child. By 2.5 years and later, you can see that the Na is picking up and the choline is. And another very important thing is that if you are looking at these integrals, you cannot compare between two machines or even MR spectroscopy done at 2 times. So these integrals are actually arbitrary scale. They can be scaled. So when you are looking at these things, so depending on the height integral, these y-axis will get automatically scaled. So if you are comparing between two sides, you should actually scale them appropriately for the same scale so that you can actually compare them. Otherwise, you can actually do the quantitative integrals and their ratios. So like I've previously told, small lactate can be seen in a preterm in newborns. Otherwise, lactate is an abnormal metabolite wherever it probably indicates anaerobic metabolism. Some people say that acetate is a more important marker for anaerobic metabolism. The sixth question is that, are the ratios metabolites really useful as it's hyped in the literature? So this is what I told. For example, in the brain tumor, you see the tumor there and there is a surrounding edema there. So a lot of metabolites can be studied, the choline, creatine, N-acetyl aspartate, lactate, lipids, and aminoacetol. And a lot of questions were asked in that. If you look at the literature from 2005 to 2010, the literature is actually flooded with all spectroscopy can do everything wonders. You can actually differentiate between. I'm not telling that it cannot, it can, but a more important and a more interesting MR imaging methods have been developed, like diffusion tensor, and perfusion, which has actually surpassed the usefulness of mass spectroscopy, in my opinion. And there are hardcore spectroscopy fans on this, and I'm not a real fan now, because I was a fan in 2005-6, but not for a brain tumor classification. So why I don't believe in choline and creatine ratio is that it's actually a ratio, just like fractional anisotropy. A lot of people believe in fractional anisotropy and absolute truth. It is not. It's actually a ratio of Q and L. So whenever there is a ratio, it depends on the numerator and the denominator. You look at this, the man, which is very fatty and also tall. He's fat, I mean, the height is 6 feet and his width is 3 feet. And compared to another small fellow who is 4 feet high and who is actually 2 feet wide. If you look at this, is just what the choline and creatine ratio in a particular voxel is doing. If the choline is increased, and if the choline is increased or the creatine is decreased, you're going to get an increase in ratio. It depends on the numerator and the denominator. So that's why the creatine, even though it is told it's a stable metabolite, it may not be a stable metabolite all the time. But how can you, for example, this is a low-grade glioma. So if you look at the low-grade glioma, previously there were ratios less than 1.7 choline creatine ratio is supposed to be a lower grade glioma. For example, this is a proved lower grade glioma, grade 2 glioma, astrocytoma. So diffuse astrocytoma in the present classification. And if you look at the choline creatine ratio is 2.95, you are not sure whether it's a low grade or a higher grade ratio. But you can also do a multivoxel spectroscopy and compare the choline from the opposite, exactly mirror image voxel from the opposite hemisphere. If you do that, this is what it is being done. If you compare with the opposite side, this is the choline into choline, or the normalized choline value. It's only 1.15. So that means the choline is actually minimally increased. So these ratios should be taken with a pinch of salt. So to prove my point, you can see this is an infarct where the choline is actually, the Na is actually reduced and the creatine is also reduced. The choline creatine ratio, because the creatine, because energy metabolism is reduced, you tend to think that the choline is increased if you are actually, the choline creatine ratio is not equivalent to an increase in choline. The choline Na ratio is not an equivalent to increase in choline or a decrease in Na. And you can see the lactate there, because any tissue with the anaerobic metabolism, an infarct or any pathology can show lactate. So the ratios may not be really important. This is always remember this fatty guy and a small guy who is actually giving you the choline creatine ratio. That's why I personally think that the choline creatine ratio is the biggest lie ever published in the literature. So a lot of people may not actually agree with me, because they'll be hardcore fans, have more experience on this. Over the last 10 years, I found that it is not really useful, like perfusion or diffusion tensor matrices. But why we need to still do is that actually to get the biopsy done. If you look at the multivoxel spectroscopy chemical shift imaging, and you can see that these color maps where the choline is high can be actually compared with the perfusion maps, and if they are actually fusing everything to the neuronavigation systems, and actually the surgeon can actually do a biopsy very precisely from there. We have actually done a study, and where when the surgeon was actually taking biopsy from the contrast enhancing lesions versus high choline by Na ratio lesions, we found a better result of a higher grade, detecting the positive result and a higher grade result when you are looking at the choline Na or choline creatine map. So having said that, the spectroscopy has got its own use. For example, this DIPG, previously called This was actually an exophytic tumor, dorsally exophytic tumor. I thought it could still be a lower grade pilocytic because the diffuse pond and gliomas will be large. Diffuse will involve in expanding the ponds, and it's mostly ventral more than dorsal. So nowadays they need a biopsy. Previously, nobody used to do a DIPG. The spectroscopy was considered to be the MR biopsy. So if the choline is increased and is reduced, pretty much diagnostic of that. Now we have to differentiate between the diffuse diffuse midline glioma. Now we call the diffuse midline glioma pontine type versus pilocytic. So a biopsy is required, and this was turned out to be a diffuse midline glioma. So the MR appearance may be very deceptive. And this is another use where you can see this is a large intraventricular tumor, calcified lesion, ventricle is dilated. We know that it's actually a choroid plexus tumor. And this is a very large and probably infiltrating into the adjacent brain. We are not sure. And look at the spectrum. And the spectrum is giving us a clue. And when you see this choline at a 3.56, I told that there should be a minocytol peak, and the minocytol peak is not very high. And this is the choroid plexus papillomas. You see a very high, large minocytol peak, whereas in carcinomas and atypical choroid plexus papillomas, the minocytol level will be low. Minocytol is an astrocytic marker. When the tumor is higher grade, minocytol level will be reduced, and when there is tumor is actually lower grade, minocytol level can be increased, and also can be seen in conditions like Alzheimer's disease. Could be only used probably in a serial follow-up in MR research of Alzheimer's disease, not really useful in the clinical practice. So depending on the minocytol, this is one area where you can actually, this spectroscopy is really useful because other things all show very high perfusion, and the diffusion will be very bright because the choroid plexus is very vascular tumor. It's not going to grade tumors. So another useful method is that in the embryonal tumors, you see like in meningiomas or extraaxial tumors, you see a lot of choline, but NAs will be almost, even though they are intraaxial tumors, NA will be almost totally lost. So if you see this pattern, it's your most of the time when you are actually looking at an intraaxial tumor, you are looking at an embryonal tumor, and which is seen in, for example, even in an adult desmoplastic variant or a sonic hedgehog variant of a medulloblastoma. You can see the choline is really high and is really low. And the other usefulness in the adult population, especially, is in the post-radiation status, and differentiate between post-radiation necrosis. When you see the radiation necrosis, even gelatinous necrosis can produce diffusion restriction. You'll not be able to differentiate radiation necrosis based only on diffusion. And when you see this peak, a very large lipid peak with all reduced choline and the low perfusion, you see because these peaks are the death peaks of lipid and lactate peak, and which may be of use. Even though I found it is not really useful, it is more importantly, T1 perfusion and T2 star perfusion is giving us more clue about the recurrence of the tumor. Even then it is really difficult, and PET may be a better gold standard for imaging. And the tumor mimics, again, we think that a lot of actually literature says that it can actually differentiate from tumor mimics. It is not always true. For example, this is a tumefactive demyelination. It has got different layers. You can see an advancing edge, which is the active areas of demyelination, which is showing a diffusion restriction. That area can show a very high choline. So if you look at only the choline and NA ratio or choline creatinine ratios, you're going to misinterpret this as a higher grade lesion. It is not. So the center part of the lesion will show lactate and lipid, and the periphery, which is actively demyelinating, will show more choline. So now the last question is that where it is really useful. So we told that where it is not really useful, where in the pediatric neurology it's really useful is in the infections and some tumors and mimics, and also most definitely in neurometabolic disorders. So for example, this is a spectroscopy. I mean, this is a diffusion scan and the T2 scan. Everybody knows that this is a pyogenic, most likely a pyogenic abscess. So that is not, the patient comes with a fever, headache, vomiting. If you see this very well diffusion restricted lesion, this with a central diffusion restriction and a peripheral vasogenic edema, you are pretty much sure that it's an abscess at least, and not although in India tubercular abscess also can be like this, or even liquid case-shaping tuberculomas can be like this. But in the acute presentation, we know that this is an abscess. So you need only a diffusion to do that. But more importantly, what you will get in doing spectroscopy? When you see this, you should always, and especially you should try to do a spectroscopy before even the first dose of antibiotic is actually gone. Even the first dose of, after the first dose of antibiotic, the spectrum can change. What you see in T, you have to do both T and small t, short t, as well as intermediate T in these cases, because you are looking at a lot of metabolites. At a 0.9 ppm, you see an upward peak. This could be a lipid macromolecular complex. And at 1.3 ppm, you see a doublet, which is actually pointing up. So this is a lipid lactate complex. We will actually compare with the T135 to decipher whether it's lipid or lactate. So, so at one point, just to the left of the lipid lactate complex, you see another peak which is there, which is actually the alanine peak. So then at 1.92, this is at 1.46, at 1.92, this is the Na peak. Don't get misinterpreted, because the machine will automatically label it as a Na, because it will, whatever it is labeled. So you should actually see which is at 2 and which is at 1.9. 1.9, you see an acetate peak. So you see alanine peak and you see an acetate peak. At 2.4, you see a large peak, which is actually the succinate peak. So we are seeing a lot of peaks. And how you compare with the 135, when you put it in the 135, you see an upward peak at 0.9, which is actually a fatty acids or the fat component or a fat macromolecular components. But at the same level, you see a downward peak at 0.9 ppm, which is actually a cytosolic amino acids like leucine, isoleucine, and valine. And when you see the lipids up and then the lactate down, and adjacent to the lactate, you see the alanine, because acetate is coming down, even still acetate is there, and succinate is a peak there. So if you see the cytosolic amino acids, you are actually most likely dealing with, in this particular clinical situation, dealing with pyogenic abscess. So the cytosolic amino acids, because the pyogenic abscesses are actually full of neutrophils, and the neutrophil degradation products lyses the protein and lyses the protein into amino acids, and you see a lot of them. And that's why the most, so that will not actually differentiate between an aerobic abscess and an anaerobic abscess. Most of the time, all these abscesses, you see aerobic abscesses, you see the lactate and the cytosolic amino acids and a small amount of alanine and even glycine. But the moment you see acetate and the succinate, so that indicates an anaerobic metabolism, because we know that the acetate and succinate, everything is actually intermediary metabolites of Krebs citric acid cell oxidative cycle, but they are in the state, they are in the steady state, the concentration of them will not be there, because they are getting completely metabolized. So they are not coming up to the enough concentration in order to get detected by MR spectroscopy. So when you get detected by, in addition to all these peaks, cytosolic amino acids, when you see all these things, you see the succinate and acetate, and when they usually in the pyogenic abscess, acetate is a larger peak than succinate. In this particular case, it is the reverse. So if the acetate to succinate ratio also can differentiate between a pyogenic abscess versus a parasitic abscess. So when you see all these things, we know that it is an anaerobic abscess, and because of the anaerobic the metabolism, these the succinate and acetate get accumulated because of conversion to oxalated acetate and malate, and then the mitochondria to get separated into succinate and acetate, and they keep accumulating. And because of that, we know that when you see all these peaks, cytosolic amino acid, the alanine plus acetate and succinate, we know that we are dealing with an abscess which is either anaerobic abscess or a combination, or a combination of true anaerobes and facultative anaerobes. In along with the anaerobes, the facultative anaerobes also can actually produce a spectrum. So we are excluding a lot of the organisms from this. It could be a streptococcus, and also we know that it is very unlikely to be a staphylococcus, even though it is a facultative anaerobe. It is not a staphylococcal abscess, because you are seeing cytosolic amino acids. In staphylococcal abscesses, you will not see much of a cytosolic amino acids. So cytosolic amino acid is your friend. when it is present, you should always think, even after antibiotic therapy, it can actually persist. You have to think of pyogenic abscess. When you're seeing all these metabolites and not seeing the cytosolic amino acids in the appropriate clinical setting, so you say that when you're not seeing the cytosolic amino acids, it is unlikely to be a staphylococcal abscess. So we are already giving the clinician a lot of information about what is the site. This is the real usefulness of spectroscopy. And these are actually first described from STPGI by Dr. R.K. Gupta's group. There were a lot of publications on this MR spectroscopy. This is what the cup citric acid cycle. We talked about malate, oxaloacetate, succinate, but because they are constantly getting actually circulated, the steady state concentration where never accumulation occurs in the aerobic cycle, but as soon as it is going into the anaerobic fermentation, you get the succinate and the acetate getting accumulated. That's why the acetate is considered to be marker for anaerobic metabolism. Supports the lactate to a certain extent. So this is how spectroscopy is really, really useful. So that's what I told. When the radiologist should be actually seeing, when you are actually seeing a case, and you should place the voxels correctly, and you should actually decide which TE spectroscopy has to be done. When 2 TE spectroscopy has to be done, it has to be done. You cannot actually call the patient and do, because patient have already received antibiotics by that time. So one of the few cases where it's really useful, because it's an intraventricular tumor, there can be a lot of differentials, including papillary tumor, the other papillary tumors. In an adult, you should always think of the meningioma in the intraventricular location, in addition to choroid plexus tumors, which is rarer in the old individuals, more common in the younger child. It's not completely abnormal to have it, but it's rare. You have to think of interventricular meningiomas as a differential. How you prove that? When you see that in meningiomas, in addition to lactate, there can be a small peak alanine. We talked about alanine at 1.46 or 1.48, 1.47, for example, a peak, which is actually, this is a low TE spectroscopy. This is a real usefulness because of J coupling and the shift. You see that the peak upwards could be lipid or lactate, and there is a peak which is left to that. It's 1.3. You have the lipid lactate peak, and then 1.48 or 47. You see the alanine peak. In 40% of meningiomas, alanine peak can be seen. And if you see that, how we prove that the small peak is alanine, at 135, it is inverting. So we know that this is not lipid, this is lactate. So to the left of lactate, alanine is keeping the same position, and this is alanine. And at 270, you have to prove further. If some people don't still believe, this could be a base, it could be a baseline artifact. You can do a longer T is 270. You can see again, the lipid is, or lactate is getting reversed, upward peak, and again you can see a small peak, which is the adjacent to the lipid, which is alanine. And when you see this, most likely you are dealing with the meningioma. The problem is that 60% of the time it will not be seen even in a meningioma. So it may not be really, really useful. So coming to the tuberculous abscess or a tuberculoma. So if you see this, the clinician, one of the most important questions which will be asked for radiologist in India at least is actually to differentiate whether it's a tuberculous abscess, a liquid caseating tuberculum, or a pyogenic abscess. And when you see the lipid and the lactate, we are pretty much sure that you are dealing probably with the absence of all other small metabolites. We are talking about tuberculous abscess or liquid caseating tuberculum. The problem is not that. When these abscesses are actually in the superficial location, the scalp fat, the adjacent scalp, I told that it is working on chemical shift. The adjacent voxel bleed can be pretty significant. There can be fat coming from the adjacent scalp. So you have to put in the normal voxels and see that there is no lipid there. So if it is there, we cannot actually rely on this. So that's why it is becoming more and more difficult even to differentiate between tuberculous abscesses, these peripheral locations. So this is a racemocystis. I told that all these metabolites, cytosolic, amino acid, acetate, lactate, alanine, succinate, everything can be seen in parasitic infections, especially in a cysticercal infection. You can see here the succinate is a higher peak than acetate in this particular case, which is actually following the published literature. And again, tuberculomas, you can see the lipid, but you should be careful that you are not reporting a lipid from the scalp. And this is, for example, another case where you can see a granuloma here treated for a tuberculoma for many years. many months, and it was not actually getting resolved. You see a spectrum, you see a lipid there, but because the patient was not getting resolved, this granuloma is not getting resolved, the surgeon decided to do a biopsy, aspiration biopsy, stereotactic aspiration biopsy, and this is what had happened. The granuloma has actually turned to meningitis, and in the Indian strain of the CSF, you can see this cryptococcal, the capsules of the cryptococcus there, and unfortunately, the patient succumbed because we have actually turned a relatively benign-looking granuloma into a meningitis, and this is the whatever you see lipid, we should not be confident that it is tuberculosis, and lipid can be seen in a lot of other conditions, including metastasis, the necrotic gliomas, as well as in fungal abscesses. And this is the classical fungal abscess where you can see the peripheral diffusion restriction. Again, you can see a large lipid peak. So coming to neonatal imaging, we are interested in hypoxia, and a lot of things told about lactate and its usefulness as a marker for permanent injury. But you should know that the lactate may be useful, but you have to be very careful, especially when you're using head cooling. The lactate as a marker for permanent damage may not be visible, and it may not be directly applicable compared to when you're actually doing head cooling. So another very important thing is that it is at 1.3 when these neonates with a very high seizure frequency, especially when they are having hypoxia or molybdenum cofactor or multiple sulfate oxidase deficiency, you load them with a phenobarbital. And with the phenobarbital, there is a solvent called 1,2-propanediol, which is showing a precision frequency at 1.1 ppm, which should not be mistaken for a 1.3 ppm lactate there. For example, this is a 1.1 ppm 1,2-propanediol, which is actually due to because you are actually loading with phenobarbital, and this is the lactate. Again, when you are actually using lactate as a prognostic measure for outcome, you should not actually misinterpret 1,2-propanediol as lactate. So some of the classic conditions where spectroscopy will be really, really useful. This everybody knows that this is maple syrup urine disease, because the classical MR appearance, the post-lymphodental capsule is swollen. There is diffusion restriction along the already myelinated fibers, the active areas of metabolism, the corticospinal tract and the visual pathway, thalamus, and we know that this is. And again, you can see cytosolic amino acids, leucine, isoleucine, and valine, and leucine is leukotoxic. That's why you get this such as the vacuolating edema of in these conditions. And why we need to do spectroscopy? Spectroscopy may be useful, especially when you're actually optimizing and normalizing the y-axis. May be useful post-treatment response, because your MR appearance will take more time to come back to normal, and the spectroscopy reduction peak may be a marker for response to therapy, especially when you're doing hemodialysis in acute crisis. This again is a very interesting case. You can see the corticospinal tract. The patient comes with hypertonia and the neonatal corticospinal tract and mid-cerebral diffusion restriction. One of the differential is non-ketotic hyperglycemia. So this is very easy to actually do spectroscopy, and unless you do both T30 and 135 or 144, both low T as well as intermediate T, you're not going to diagnose this condition. So you see lactate, and you see at 3.56 a peak. At a low T, you see a peak at 3.56. You are not going to differentiate whether it is minoxidil, which is a normal high peak in a neonatal brain, versus glycine. For example, the glycine at 144, if you're doing an intermediate T, the minoxidil should come down, because minoxidil has got a lower T2 value compared to glycine. The glycine persists. So you have to do both T30 at our intermediate T, both T, low T and intermediate T, in order to differentiate between minoxidil and glycine. Just doing a 135 and seeing a peak at 3.56, you cannot actually infer that it is glycine, even in the appropriate clinical situation. So you have to do an intermediate. That's why somebody should be monitoring, especially a radiologist should be monitoring, decide on the spectrum. It's not very easy to do spectroscopy in these sick children, and especially to decide on another spectrum, an intermediate spectrum. So glycine can also be seen in central neurocytomas, which is of academic interest. I don't go into the details which are published. Another very interesting this case is actually given to me by Cesar Alves, who was actually shown that in this particular case, you can see this is a diffuse white matter environment, osmotic edema of the white matter. You can see this is a case of galactosemia. You can see at 3.7 ppm, you see in T30 as well as 135, you see a peak which is very high, which is more seen both in T30 as well as 135, but it is better in T330. And in published literature, it says that in the intermediate TE, it can even reverse. But I've actually seen two cases, which is another case which is published in the literature. And this is also another case given by Lazarov and also Prasad, who has actually given me this case. And you can see that the spectroscopy at 3.56 to 3.7, actually there are multiple peaks on galactitol as well as galactose, which can be detected from 3.7 to 4.2. So this is again useful in a particular case where you have to do both T 30 and 135. In this particular case, you can see again, because of the difference in T2 values at 135, the height and the integral of the peak is actually coming down. So again, one more reason to believe that it is galactitol, because a lot of peaks can be there in this between 3 and 3.2 and 3.9 is actually a very difficult area to decipher, because at 3.7 you have the galactitol, then at 3.8 you have the phosphoserine, which is a marker in tuberculosis. At 3.7, 3.6 again, 3.7 again you have the trihulose sugars, a lot of sugars in glucose, the galactitol. All these things are there, and it is very difficult to differentiate between them on a 1.5 Tesla marker, even though in a given case with the as an adjunct to MR imaging, it will be really useful. One case where it is really useful, maybe again it is questioned whether it is really useful because the rarity of the syndrome. For example, this is the only area where the spectroscopy is actually showing an abnormality. This creatine peak is absent. We know that is a congenital creatine deficiency syndrome, either transporter deficiency or amped mutations, and whether some of them will respond to creatine supplementation, others won't. And so when you see this is a normal 3 ppm, this is a normal, I put a normal spectrum here in order to have a reference. And you see, you're not seeing a 3 ppm, you're not seeing, and it can actually come back after treatment if the patient is responding. It's another case given to me by Dr. Gopinath from Chennai. Another case, MR is relatively looking normal, and the patient has got a global developmental delay, and the seizures, you should always do a spectroscopy when you are looking at when you are having nothing, especially when you have seen only a mild delay in myelination or something like that. So when there is a global developmental delay and specific autistic features, you should think of the creatine deficiency lesion also. So the mitochondrial disease, lot of things told about lactate in mitochondrial disease. The problem is that if you put in a MELA syndrome, if you put in the subnormal voxels, any lesion, there will be lactate. So you have to put in the normal looking white matter and the gray matter. And if still lactate is there, maybe it's suggestive that you're dealing with a mitochondrial disease. So LBSL is another condition, again diagnosed more on basis of MR imaging appearance, and this large lactate peak will give you a clue to the LBSL, the diagnosis. So phenylketonuria, again, diagnosed based on MR imaging appearance and the clinical presentation. And we can see the peritrigonal white matter diffusion restriction and white matter hyperintensity, non-specific findings. And at 7 point, you usually see it only till 4 ppm. So you have to actually, you can actually widen this, the x-axis if you do the post-processing. Actually, the spectral details are there. And you can see that you look at 7.4 ppm in this case, we can see that a phenylalanine peak, and which can again be diagnosed. This is a case of L2-hydroxyglutaric aciduria, again diagnosed based on MR imaging and spectroscopy. At a 2.4 ppm, you see the 2-hydroxyglutarate. The problem is that you see succinate there, you see the GLX there. So how do you know that this is a normal GLX which is seen in one T30 or 135? Or is it actually, this is actually 135 spectrum, sorry, this is not T30. So 2-hydroxyglutarate there, and it is not very easy. It's again hide up in to differentiate between the LDH mutant, IDH mutant gliomas, you see 2-hydroxyglutarate, this time it is a D2-hydroxyglutarate is in tumors, and it is there are several papers, but it is really difficult actually to find out whether this is actually to differentiate GABA, glutamate, and GLX and the succinate. So this may be useful because you see the peritoneal white matter, the classical presentation, you see the epthesis and the skin changes, and where you see in 135 or an intermediate T, a large peak up at 1.3. This is not lactate, this is lipid, and this is a case of Sjogren-Larsen syndrome where you can see a lipid resonance. So there are specific conditions where it will be useful, like for example, Canavan-Salas disease. Canavan is probably the only condition where the Na is actually increasing. In Salas, because of the neuraminic acid increase, you see Na is like peak. So because of the interest of time, I will finish it in another 5 minutes. I will not go into the details of the research sequences. Spectroscopy may be useful in epilepsy imaging, but you should know that the normally itself Na is actually smaller. I mean, is lower in concentration in the head of the hippocampus, and the posteriorly the tail of the hippocampus Na is higher, and the choline is just the reverse. So when you're reporting, you should. I will not go. I'll skip these lesions. This is a case of the colloid cyst or a neuroenteric cyst. We can see a Na-like peak in these cases of all these, which is a marker of these Warthin's glands and the ciliated pseudostratified ciliated columnar epithelium. So if you see this large Na peak, you don't expect a Na in the foregut duplication cyst. So what you're seeing is the N-acetyl moiety of the sugars which are present, the N-acetyl glucosamine and the galactosamine, which have actually published some time back in JMRI. And this is another case, is a 62-year-old male with a recent onset dementia with the frontal lobe symptoms, a large cyst. When we did in cysts, we do spectroscopy, you see NA reverse peak there. So we are not sure what it is actually, the histopathology. If you look at this, this is what happens in this thing. So this reversal is basically because it is not phase corrected. So if you do the phase correction, you can actually reverse this back to this. So it's again an NA-like peak because of the N-acetyl glucosamine, galactosamine. You see, this is how these they do phase correction. This is the NA reversal peak. So which is just because it is a phase reversal which has happened, and with post-processing, you can actually make this NA-like peak upwards. So a lot of things can be done. You can see this lipid macromolecular complex coming down. So this is again another pitfall in spectroscopy, and this turned out to be a neuroenteric cyst in a very unusual, uncommon location in an elderly patient. So Na-like peak may be a marker. So having told about that, we do a lot of research, and we had a very bright postdoc student who's right now doing a postdoc in US. She did a lot of work on functional spectroscopy. So she did a functional MRI as well as spectroscopy at the dorsolateral prefrontal cortex, where the patient is actually performing N- task, and she said that she found out that the glutamate concentration and the neurotransmitter concentration increases when the subject is performing, and it may be useful in differentiate between in a mild cognitive impairment versus others. We have actually looked at normal volunteers, how their the contribution of these neurotransmitter changes when the patient is actually performing these cognitive tasks. So to conclude, the take-home message is that the quality of the spectrum is very important, and you should know when to do spectroscopy and what TE should be used, and how the spectrum should be acquired. And if you are not going to diagnose something on the console, you are not going to diagnose outside the console, and especially true for MR spectroscopy. And the take care of the shiming and your sequence, your meshing is very important. You should have at least a third of shiming in order to get good spectrum. The technical considerations are much more important in MR spectroscopy compared to routine sequences. Post-processing is equally important, because I told about the not reported in the literature reversal of Na, which is just a phase reversal which can be corrected with the phase processing. And never report MRS in isolation. If you report MRS in isolation, not looking at your MRI images, you are going to end up in trouble. And beware of these pitfalls and of the published ratios. And if you look at somebody else's published ratios, may not work for you in your machine. And thank you very much for your kind attention. If there are questions, I'm happy to answer.
Thank you, sir. I think for that absolutely wonderful presentation. And we have some questions. I'll be asking you then. So there is, we'll start with this, that in a brain abscess, if there is absence of cytosolic amino acids, then we consider staph, we exclude staph and don't give vancomycin. And is that true that?
No. You cannot actually depend entirely on MR spectroscopy for deciding treatment. It's just because before you aspirate, you have a basic idea what you are going to do. This is not a MR spectroscopy is not a shortcut for doing an aspiration in a pyogenic abscess or getting the microbiology done, because these are in the published literature. These are the common findings, the most common findings. Just because the little bit of amino acid is seen in a staph abscess, we cannot say that, because staph is also an organism. There will be neutrophils, and the neutrophils will lyse and it will produce amino acid disintegration. But staph will not produce as much cytosolic amino acid compared to other anaerobic or aerobic abscesses. That's what I meant.
And can this be used for monitoring treatment in brain abscesses?
It can be used, but the problem is that it is very difficult to quantify. Unless you quantify, if you're just looking at the peaks, you are not going to say whether it's actually going better or not. Having said that, when the patient is responding, you see this acetate, lactate, all those things coming down. But I don't think anybody is using serial MRI just to monitor brain abscess response. Even that the MR findings will actually lag behind clinical response. So I don't think spectroscopy in isolation is going to do good, because you cannot actually keep the patient doing, and these are very expensive methods to prognosticate.
Do you look for Trehalose peak in fungal infections?
Yeah, that's what people are interested in Trehalose because of the publication from CPGA group, and that is because in 1.5 Tesla especially, it is not possible. I told between 3.2 to 3.9, it is a very busy area, and it is like a lot of the aircrafts are there in the sky. You're not going to differentiate between, for example, a phosphoserine peak, which can be seen in tuberculosis, a Trehalose peak, which is more specific for a fungal abscess, versus galactitol peak, or something like myoinositol or glycine. So it is very, in my opinion, it is very, very difficult to differentiate these peaks from the Trehalose peak. So I don't look at Trehalose peak for diagnosing a fungal abscess. I look at the diffusion imaging more than spectroscopy to differentiate that.
Okay, sir. Can MRS help differentiating between tubercular versus fungal abscesses? We talked about tubercular versus bacterial, but what about with fungal?
Theoretically, yes, because if you aspirate and do spectrometry in the very high Tesla spectrometers, probably you can look at the Trehalose peak, you can differentiate from phosphoserine. In the clinical perspective, almost all the time, it is very difficult because both will show lipid, and most of the time you depend on lipid. And in very specialized centers where they have actually experience on a 3T or a higher magnet where you can differentiate Trehalose, may be a good idea. In my experience, I cannot.
And this, if a MRS is done after relative recovery from an acute phase of metabolic encephalopathy, how long does the MRS change? How long do these changes persist after the child biochemical correction? Can these changes persist for some time, or they?
I have no idea, because I don't think people are doing serial MRIs, MR spectroscopy for that. And to find out an MR spectroscopy in the appropriate case in the literature itself is very difficult, because very few people are doing spectroscopy. Most people don't believe in spectroscopy because of the flooded literature and actually corruption of literature with the over hyped up use of a spectroscopy. Spectroscopy should be used for the correct purpose. And I'm sure that it is a very good method probably to prognosticate, but it is very difficult to get these children into the MR magnet again and again. And I don't think anybody using that, except I've seen in sick kids that they were using spectroscopy to prognosticate maple syrup urine disease to hemodialysis.
So it's a question from Dr. Gauri. Why are there two creatine peaks?
To be specific, I don't know, because creatine is phosphocreatine, creatine, and a mixture of all the things. In 1.5 Tesla at 3 ppm, you cannot differentiate between phosphocreatine and creatine. But with 7 Tesla, you can actually differentiate. There is a second basically you are looking at the methyl and the methylene groups. So methylene groups usually will be at a different space compared to methyl groups. So I think it is also true for the, I'm not very sure about that, the 3.9 probably is representing a methylene group of creatine.
How useful is phosphorus spectroscopy in muscles in mitochondrial disorders? We did not talk about it today, but
yeah, I have not looked at the phosphorus spectroscopy. There were a lot of interest in phosphorus spectroscopy. Specific groups are using it for the muscle disorders. Initially, when I started in 2005, I also did some spectroscopy, and I saw that the phosphocreatine, there was some difference. I forgot the metabolites between when the patient is at rest compared to after an exercise, and we were very excited, and we looked at some of the myopathies, and we cannot actually differentiate. T1 weighted axial scan will differentiate better than phosphorus spectroscopy, and it's very difficult to do, and it's more expensive to do.
does prematurity?
Yeah, it's a good technique for research, not for clinical use.
Not for okay, sir. So does prematurity in HI affect MRS findings in a metabolic disorder? We talked about some of the prematurity and HI.
Hypoxic ischemia?
Yeah, hypoxic
so yes, the prematurity will definitely, in premature infants, small amount of lactate is supposed to be normal. So in hypoxic ischemia, lactate level can increase, and lactate is actually a marker for prognostication. But again, this quantitation is the most important difficult thing. You cannot say that it's a small lactate. This is just because it is scaled up, it can appear small, because visually you are not going to diagnose. And the absolute quantitation of lactate is a very important, difficult proposition in spectroscopy. It can be done, but it takes more time. It is done only in the research in setting, not in the clinical setting.
So Dr. Rajesh Nair has asked, in your experience, out of all the MRS you did, in what percentage did it really make a real difference to the diagnosis?
Depends on what conditions you are looking at. Whether you are looking at neuromitochondrial diseases or metabolic disorders, I think it is at least 50% of cases it is going to make a difference, especially the cases which I have told about. But in the case of tumors, I must say that it is not really useful, even though in the literature is flooded with the spectroscopy of tumors. It may not be very useful. It may be useful in probably less than 20% of cases. So in abscesses, it is going to be very, very important, and especially we need to differentiate between aerobic bases and anaerobic abscesses. So neurometabolic and abscesses are the two conditions which I prefer, and I like to do spectroscopy than anything else.
Yes, and I think even pediatric neurologists, we are more interested in these conditions more than tumors. We are not surgeons to be interested in tumors. So another question is that what protocol should be used and what sites should be done in a normal MRI in a child who is suspected inborn error of metabolism or developmental delay. So we all have this question.
Yeah. So when the MR looks normal, where should you put the voxel? That is the question.
Yes.
There are institutional conventions. You can put pretty much everywhere, anywhere you like, because most likely because of the high metabolic demand and the chance of detecting a signal, most people will do at least one single voxel spectrum in the basal ganglia. And I think it is in the left basal ganglia in Citric and the right peritrigonal. I don't remember exactly. Right peritrigonal white matter. So you're interested in the white matter as well as the gray matter. The gray matter, you can put it in the basal ganglia. So if you're developing a system, I think you should continue to do the same convention. So if you're looking at the left basal ganglia and right peritrigonal white matter, some published literature says that. I don't exactly know. I don't remember. It is more than 11 years now in Citric. They were using, I think it is right or left basal ganglia, and the opposite peritrigonal white matter for another spectrum. So if you are looking at normal spectrum. So if you put, another very interesting thing is that you can actually do real-time spectroscopy, like our postdoc student Anupa has done. You can actually put the when you're actually acquiring a spectrum, you can see it real time. So when you see no creatine, you can actually do that. When you see when you see creatine, you are no longer interested in continuing this thing. You can just take a screenshot and stop. So in less than 1 minute, you are actually making a diagnosis. So most people will wait for everything to come. So the MR is actually a very versatile machine. We are not even using 1% of the capability.
Okay, sir. And any experience with MRS in cellular or supracellular masses?
I have no experience, and cellular supercellular masses, unless they are something like a large neuroenteric cyst, which I'm interested in because we published for the first time the N-acetyl glucosamine and galactosamine. So otherwise, you are not going to differentiate between a craniopharyngioma and other tumors, or a pituitary macroadenoma versus other tumors with spectroscopy. Another very important thing is that it's very difficult to do spectroscopy at this location because of the adjacent bones, and you are not going to get a good spectrum there.
So I think I have one question, sir. How much can we rely on the computer software must be marking these peaks for you, the artificial intelligence?
Yeah.
So how much do we have to know, and how much can we rely? Because as clinicians, we cannot remember everything. So
yeah. So the normal ones, the choline, creatine, and NA, second creatine, sometimes minus it will be marked by the machines. This is because of the FDA regulations. FDA, unless they are pretty much sure, you are not supposed to automatically mark all these things. Because a lot of, for example, I told that a reversed NA peak, if the machine is automatically marked, it will mark as not as an NA-like peak. So, you ideally you can do a spectral editing, and you can actually mark manually, but the technologists can do, and the radiologist has to validate it, and it can directly go. So they can actually do that and actually mark, because I have shown all these marked on the machine, not I have actually added. So that is because we are doing that spectral the spectral peaks we are actually editing, and it's actually marking on the machine itself. So that is possible, but somebody has to take responsibility for marking that. That is usually done by a radiologist. Under supervision, a radiology technologist can do that, but radiologist has to validate and vet that.
That would be very
another very important thing is that sometimes creatine can be slightly shifted in 1.5, so it will not be always in the 2 ppm dot. Or for example, your cytosolic amino acid will not be in the 0.9, it can be 0.8 or more towards 1 in 1.5 Tesla, because the spectral broadening is there. So if the spectral separation will be much better if you use, for example, a 7 Tesla, so it will precise exactly. So if you do a spectrometry, even it will be even better. So another very interesting thing which you all can do is that the spectrometry of the urine spectrometry. So a lot of things, for example, galactosemia, with 1 drop of urine actually diagnosed in 5 seconds. I mean, I'm exaggerating. If you have to have a very expensive machine to do that, and you need a deuterium oxide and this thing. Put that, you see the galactitol peak. In spectroscopy of the brain, it is very difficult to differentiate it is a galactitol or something else. Whereas you see the triplet at 3.7 to 4.2 and the galactose in the 4.2, you are pretty much sure that it is galactosemia. And I'm sure that you have a better methods to diagnose galactosemia, and screening, it is actually one of the conditions where it's screened. But urine spectrometry is a very interesting thing which you can do. There's a lot of research.
I think, sir, thank you for the absolutely excellent talk. We learned so much, and I think we'll be looking at it with more confidence than before. And they were around 220 attendees maximum time today. So this is a very much looked for talk, and we really enjoyed it. And thank you so much, sir.
Thank you very much for this opportunity. Thank you.
Yes, yes, yes. We'll finish now.